that we also understand that when you're stressed, you don't sleep. And we know that abnormal sleep patterns also interrupts your immune system and increases your risk for developing cancer. Where did we get this evidence? Well, we know, for instance, nurses that work the night shift have higher rates of breast cancer than nurses that work the day shift. Because see, at night when you go to sleep and in darkness, your body is rejuvenating itself with melatonin levels, with cortisol levels, and if you're getting abnormal sleep, then that is a stressful event on your body. We also know, for instance, that flight attendants have higher rates of breast cancer because of the abnormal sleep patterns and the type of stressful environment under which they work. So I encourage you that if you have stress in your life, to do whatever you can. You know, I'm from the Caribbean, and we always say, no problem, man, I'll get through it tomorrow. I just recommend that you do whatever you can. Pray, meditate on a daily basis to eliminate stress in your life. Now, the whole issue of oral contraception, there is no evidence to suggest at this point that the use of the birth control pill increases your risk for developing breast cancer. However, this is not the story when it comes to hormone replacement therapy, when in fact hormone replacement therapy pills were given out in this country very much the same way that pediatricians used to give out lollipops in pediatric offices. It was the same thing in gynecologist offices where prescriptions for hormone replacement therapy were just routinely given to women in this country. And in fact, if you looked at the SEER data, looking at rates of breast cancer in this country, we saw that as hormone replacement therapy use went up, the rates of breast cancer also started to go up in the United States. And in fact, over the last 2 years, there have been major class action lawsuits against the makers of hormone replacement therapy pills because of the increasing rates of breast cancer. And what is the issue so that you understand it? Well, when hormone replacement therapy first came out for women in the early 70s, we were given unopposed estrogen by itself to women to help with symptoms of menopause. What we found was giving unopposed estrogen actually increased your risk for developing uterine cancer. So then we got smarter and we started adding to that progesterone, which is the other hormone that gets secreted during the menstrual cycle to help with the hot flashes, and we found that progesterone did not increase, actually took away the risk for developing endometrial cancer. But as a progesterone was a double whammy to the breast, and we've seen increasing rates of breast cancer in those women who have used hormone replacement therapy for more than 5 years. And believe it or not, a large study done out of Howard University in conjunction with Essence Magazine, the rates for African American women were even greater in thin African American women who were using hormone replacement therapy. The risk was even greater for you when you were taking hormone replacement therapy. So if you are, I suggest that you have a conversation with your physician about whether or not you should be continuing on hormone replacement therapy if you've been on it for more than 5 years, and that if you are on it, that you're using it at the very smallest dose to help you with the menopausal symptoms that you may be experiencing. Hit it again. There are some other things that I'm going to just mention briefly, that because a lot of women always ask about these issues. Antiperspirants and deodorants, do they cause breast cancer? Well, there's no evidence to suggest that. However, there is research that shows that 98% of the leave-on products that you as women use, and about 90% of the rinse-off products that you use, contains a substance called parabens. Now, what do I mean by leave-on products and rinse-off products? Leave-on products like mascara, lipstick, foundation, blush, I think, or rouge you call it. Rinse-off products like shampoo, conditioner, contains a substance called parabens, and these parabens are used to keep these substances sterile on the shelf, on the drugstore, so that they don't get bacteria. What we found in one study where they looked at breast cancer tissue, 100% of that breast cancer tissue had these paraben substances in it. And we don't know what effect it may have had on the breast cancer, but they are easily absorbed through the skin. That's what we know. We now need to study normal breast tissue and breast tissue that may have had a biopsy that shows some abnormal findings, to see if we see a difference in the level of these parabens between breast cancer tissue and normal tissue. Antibiotics, one study showing that if you use antibiotics in your 20s, and lots of antibiotics, that it may increase your risk of breast cancer. No real credible evidence. Underwire bras, I get this question all the time. Underwire bras, does it cause breast cancer? No, it doesn't. However, I will say most of the women in my office don't wear the proper bra, and that it causes breast pain. And I recommend that to the women, whenever I speak to women anywhere, that you get measured annually for the proper bra size, because a change in 3 to 5 pounds in your body weight can throw off your bra size as well as your shoe size. So please get measured appropriately. Going braless doesn't increase your risk for developing breast cancer. And then many women say to me, especially in the Caribbean, I get this one a lot, not that hit my breast. Well, having a hit or getting, hit in your breast also doesn't increase your risk for breast cancer either. And breastfeeding does seem to have a protective effect against breast cancer, but you would have to be breastfeeding continuously for about 9 years. Talk about being barefoot and pregnant in the kitchen. But you have to be breastfeeding continuously for 9 years. I think if you're not enrolled in that, in doing that, to have any kind of protective effect. So I'd like to move on very quickly to what's new in the area of screening and diagnosis, very quickly, because despite all of the advances that we've made in the treatment of breast cancer, the best thing that we have in the defense of breast cancer is early detection. Mammogram still is the gold standard, and we recommend all women over the age of 40 that you get a mammogram, unless, of course, you have a family history of breast cancer, and then we recommend that you get started 10 years earlier than the youngest first-degree relative in your family. So if you have a sister that was diagnosed at age 42, you should start at age 32. Now, for women who don't have a family history of breast cancer, and if you're African American, I actually start you at age 35, like I said to you, because African American women have higher risk of breast cancer under the age of 50. And I know that insurance companies don't want to pay for it, so I make up a diagnosis. And if any of you ever tell an insurance company that I just said that, I can't really lie, but that's what I do. That's my screening practice for African Americans. We also use ultrasounds in the diagnosis of breast cancer, and more increasingly now we're using breast MRI, because we know that young women in particular who have more fibrocystic breasts, on the mammogram the breast looks very, very white, and we can miss a lot of things on the mammogram. So we use breast MRI, which uses magnetic waves to actually see through the breast, and what that does is we can see early developing blood vessels that actually can feed an early tumor, and that's why breast MRI has become more important, particularly in women who are at risk for developing breast cancer and in women who have already been diagnosed with breast cancer, to actually better determine the extent of disease. And I'm going to talk to you a little bit more about this early developing blood vessels and the difference that it makes. We also sometimes will look at nipple aspirate or nipple discharge from the breast to look for abnormal cells. Something called duct endoscopy, which I'm going to show you a little video quickly looking into a milk duct. And then something called a Dobie scan, which is also using light transmission, and thermography looking using heat to actually look for these early breast cancer. So this is the Dobie scan. It's also called a comfort scan because it has gel padding. It's nice and soft. For the guys out there who've never had a mammogram, I understand it's like putting your breast in between a refrigerator door. So we're coming up with something that's a lot more comfortable. And I know the women always say, see, if you had to screen for you know what kind of cancer they have. But the comfort scan is very, and here's what I'm talking about. If you look right here, this is an early developing breast cancer, and this is a little blood capillary off to the side. What cancers do is that they secrete hormones that tell this little capillary, feed me. And that capillary starts to send little blood vessels over to that tumor. And about the time that that cancer hits about 1 centimeter in size, which is when a mammogram will pick up that cancer. You can see it's much bigger than when you got it before the blood vessels were over there. And by the time the blood vessels are there, cancer cells can get into those blood vessels and it can spread to elsewhere in the body. And you don't die from breast cancer in the breast. You die if breast cancer spreads elsewhere in the body to like the lungs, the liver, the bones, or the brain. And again, this is another example of the sentinel scan. You can stop right here now. And that sentinel scan is using heat to see the differences in blood flow, because blood flow, increased blood flow brings more heat into the breast, and we can examine particular areas of the breast where we can see increased heat. Standard mammogram, dense white tissue, okay? On this mammogram, completely normal, left breast. Again, another view of the left breast, looks completely normal, but you've got this dense white tissue right here. This woman then had the sentinel scan. I'm not sure what just happened. And on the sentinel scan, she had a hot spot right here in the right breast and also in the left breast. And she was really only concerned about something in her left breast, and both of them lit up. It turns out that these two areas were biopsied. She had a breast cancer in both breasts that was missed on the mammogram. So these are early developing lesions that were missed. So again, I just wanted to give you a sense of what's on the horizon, because we've got some new modalities that will help. And just a second here, if this video please come on. There it is. We're looking into a milk duct right now. This is actually looking into the nipple, and there's an early breast cancer. And this is with using a telescope that's about as thick as a hair on my head. And that's an early breast cancer that we're finding even before a mammogram or an ultrasound picked it up, because this woman came in with bloody nipple discharge, and we're now able to look into the milk duct. There's a normal milk duct, and we're able to look down into the milk duct, and we can see an early developing pregnancy. This is just normal here, but in the earlier you saw where the tumor was actually developing within the milk duct. Again, there it is, right there. Okay? Next one. So that's where we are. That's where we are in terms of early detection and diagnosis. We've got great things on the horizon. Very quickly, I want to just go over some of the treatment stuff that we're doing now, mainly because it pertains to this whole concept of survivorship. In the treatment of breast cancer, we used to years ago always routinely take off the breast. Now many of you know we can do a lumpectomy where we can conserve the breast. And then followed by a lumpectomy, we always have to use radiation therapy in order to prevent breast cancer from coming back in that breast. Now, what we do know is that with lumpectomy now, what we can also do, and with mastectomy, we can do something called the sentinel lymph node biopsy. Years ago, women always had all of the lymph nodes removed. That increased their risk of getting swelling in the arm, infections in the arm. You couldn't go for a manicure, pedicure, you couldn't garden. You had to watch how you were cooking so you didn't get burned. Now we can remove the first lymph node that's being drained by the cancer, and if during the operation, if that cancer hasn't spread to that lymph node, we can stop the operation at that point and save the woman the risk of having those terrible complications. But I wanted to talk to you about the work that we can do in those women who do have to have a mastectomy. Years ago, this is what would have happened to a woman who had a mastectomy. These are some pictures of my own patients. Here's a patient who had a right mastectomy years ago. And then what would have happened is she would have come back in maybe 3 to 6 months later after treatment. We would have harvested fat and muscle from the abdomen and reconstructed the breast with what we call a tram flap. And you can see this is actually a very nice result. We've got great volume in the breast. But unfortunately, you've got this scar. And if this patient wanted to wear a strapless gown or go to the beach, it limits the kind of clothing that she can wear. And we know how you women are about what you can wear and stuff like that. So what if we could improve on this, because we know look good, feel better. So next slide, please. Next slide. So here's an example of a woman who came in with a breast cancer right here in the left breast. Okay, and in her case, because of the type of cancer that she had, she too needed a mastectomy. What if we could remove the entire breast by just making an incision around the nipple areola and remove the entire breast through that small incision? And here's an example of that. This is the reconstructed breast, believe it or not. This is how this patient woke up after the operation, except for the nipple, which we reconstructed later. But you can see great volume, and this is with harvesting tissue from her back and slipping a small implant into the breast. You can see in this patient's case, she can go out, no one would ever know. Another example of a woman, in this case, her breast cancer was in this area of her breast. I used the same technique, which is what we call skin sparing mastectomy. By skin sparing, what I mean is I make my incision only around the areola, preserving all of the skin so that you continue to have the sensitivity of the skin. Next slide. And in this case, we used muscle and fat from the abdomen, and we reconstructed the breast, and again, another great result. And I just have to tell you a really funny story with one of my patients. It's funny and it's inspiring at the same time. I had a patient who, African-American woman, nurse, who had come in with breast cancer, and I tried 3 times to conserve her breast, to keep her breast by doing lumpectomy, and we just couldn't save the breast. And so we had to do a mastectomy, we did skin sparing, immediate reconstruction. And one of the things that you should know is that we call this a 2-for-1 procedure because when we take the muscle and fat from the abdomen, we lipo give you a nice looking 6-pack, make it look really great. And this woman never smiled at me when she came into my office. In fact, I was convinced she hated me. I didn't even understand why she stayed with me, but I took great care of her. She comes in for a follow-up visit. I open the door, and she's standing there with just her underwear on. She goes, "Look at me!" I said to her, put your clothes on before they arrest you. It was an activity for my patient. But I share that story with you because it really points to the survivorship issue that I'm talking about. A diagnosis of breast cancer is bad enough, but if you can leave a woman feeling that empowered after the diagnosis of breast cancer that she's that happy, it makes a tremendous difference. Okay? And I'm just going to, one last slide that I want to keep going. What I'm going to talk about lastly, and I'll end there when it comes to this whole concept of survivorship issues. One of the things that we pay very close attention now to is instead of just treating women with breast cancer, we think about how we're treating the patient with breast cancer. And we've got a number of new treatments like radiation therapy. We're now able to deliver it instead of coming in every 6 weeks for radiation therapy. We can deliver it like this right here in the operating room. There's the breast cancer. The cancer's been removed. We can put a probe right into the breast while the woman is asleep. There it is right now. And we can deliver the radiation therapy over 30 minutes right there in the operating room. After the lumpectomy, you have your radiation, and you go home and you're done with treatment. But lastly, and we've got a lot of great things with chemotherapy that we're doing well and women are living longer. But the thing that I want to say that is very important is this whole concept of complementary therapy. Stop right there. And what I want to say about this is that one of the things that I train young physicians who are training under me about the treatment of breast cancer is that the woman that comes into your office is not a 32-year-old stage 2 breast cancer that you just got to do breast surgery followed with chemotherapy and radiation therapy. You really have to understand the entire picture and the entire life of that woman coming into your office, because your goal is to not have that woman just survive breast cancer. Your goal is to have her be living fully in life. And what do I mean by that? If African American women are getting breast cancer at earlier ages, and a 29-year-old African American woman comes into my office who has never been married with a diagnosis of breast cancer, and she's concerned about possibly getting married and having children, then it's important to me that I leave her if she needs a mastectomy with a cosmetic result like that, because if not, what we're dealing with is a woman who's embarrassed to take her clothes off, a woman who's embarrassed to be